Hello everyone and welcome to our module on adrenal insufficiency. Adrenal insufficiency refers to loss of adrenal function, and by this I mean loss of production by the adrenal glands of one or more of the adrenal hormones. All forms of adrenal insufficiency involve loss of production of glucocorticoids, meaning cortisol. And then some forms also involve loss of production of mineralocorticoids like aldosterone and androgens from the adrenal gland, and the chief androgen that comes from the adrenal glands is dehydroepiandrosterone, or DHEA. There are a couple of types of adrenal insufficiency. The first is called primary adrenal insufficiency. This is also sometimes referred to as Addison's disease. In primary adrenal insufficiency, there's destruction of adrenal gland tissue, and this leads to loss of all adrenal gland hormones, including cortisol, aldosterone, and androgens. Secondary or tertiary adrenal insufficiency are collectively called central adrenal insufficiency, and they get this name because there's a central cause where there's lack of stimulation of the adrenal gland to produce cortisol. In secondary adrenal insufficiency, there's loss of ACTH from the pituitary gland. In tertiary adrenal insufficiency, there's loss of CRH from the hypothalamus. And in both of these conditions, you have loss of cortisol only, not loss of aldosterone and androgens. Let's talk about the clinical features that can occur when there's loss of cortisol and glucocorticoid deficiency in a patient who has adrenal insufficiency. First of all, when you lose cortisol levels, patients become fatigued and they lose weight. Beyond this, gastrointestinal symptoms are often prominent when patients have cortisol deficiency. Usually they have nausea, and sometimes they also have vomiting, abdominal pain, or diarrhea. Because cortisol maintains vascular tone and therefore blood pressure, when patients are deficient in cortisol, they can develop hypotension, and sometimes this can lead to syncope. Usually the hypotension that is associated with cortisol deficiency is orthostatic hypotension, meaning that when patients stand, their blood pressure drops a lot. So patients often have low blood pressure at rest, and when they stand up, it can get even lower, and that sometimes leads to orthostatic syncope. And then muscle and joint pains can develop when patients have cortisol deficiency. And finally, cortisol deficiency is in the differential for hyponatremia. That's because when the cortisol levels get low, there's more ADH release, and this can lead to the syndrome of inappropriate ADH release and hyponatremia. When patients have deficiency of mineralocorticoids like aldosterone, they can develop hypovolemia. If you look at the bottom right side of the screen, these are the major functions of the hormone aldosterone. It pulls sodium from the urine into the blood, and it excretes acid and potassium into the urine. So when patients have a mineralocorticoid deficiency, there will be lots of sodium going out in the urine, and that will take volume with it. So these patients develop hypovolemia. Because these patients lose sodium in the urine, they are said to have salt wasting, and they sometimes will crave salty foods. That's a classic feature of the hypovolemia from aldosterone insufficiency. And sometimes, because of the amount of sodium and water that's going out in the urine, patients can potentially develop hypovolemic shock if they don't consume enough electrolytes and water. Other features of aldosterone deficiency include hyponatremia. That's because when patients lose volume, their ADH level is high and they retain free water, and this tends to lead to the development of hyponatremia. They can also develop hyperkalemia and metabolic acidosis, and that's because of these normal functions of aldosterone. When they are lost, there's less urinary potassium and less urinary acid excretion, and that can lead to hyperkalemia and metabolic acidosis. And then finally, let's talk about the clinical features of androgen deficiency when DHEA levels fall. In males, there's usually no significant impact because males produce lots of androgens from the testes. In women, there can be decreased axillary and pubic hair, and that's because the androgens from the adrenal glands are responsible for development of axillary and pubic hair. So now that we've gone through all that and you understand what the deficiency of the different hormones leads to, we can talk about what happens when patients have primary adrenal insufficiency. Remember, this is what occurs when there's destruction of the adrenal gland. These patients will lose all production of adrenal hormones. So first of all, they will present with fatigue, weight loss, nausea, vomiting, and abdominal pain. Now these symptoms are incredibly nonspecific, and they go with lots of other disorders that are much more common than adrenal insufficiency. And so for this reason, the diagnosis of primary adrenal insufficiency is famous for being missed. If you ever meet a patient who has this condition, they will usually tell you that they saw lots and lots of doctors for their complaints, and they were told that they had gastroenteritis or irritable bowel syndrome or something other than adrenal insufficiency, and that's because these symptoms are so nonspecific. Other symptoms you can see are muscle and joint pain, postural hypotension, salt craving from the loss of aldosterone, hyponatremia, hyperkalemia, and finally, eosinophilia often occurs in primary adrenal insufficiency. Most patients don't have this, but there is a significant minority that does have eosinophilia. The reason for why this occurs in primary adrenal insufficiency is not well understood. There is one special feature of primary adrenal insufficiency that can help you make the diagnosis, and this is unrelated to loss of adrenal hormones, and that's skin hyperpigmentation. So in primary adrenal insufficiency, the ACTH level is going to be high. That's because the pituitary gland is responding to the loss of cortisol and releasing more ACTH. Well, whenever more ACTH is released from the pituitary gland, the level of melanocyte stimulating hormone, or MSH, also goes up. That's because MSH shares a common precursor protein in the pituitary with ACTH. It's called propiomelanocortin, or POMC. And so to make more ACTH, the pituitary gland makes more POMC. That will be used to raise the ACTH level, but it will also end up raising the MSH level, and MSH drives melanin synthesis. So patients who have high ACTH from primary adrenal insufficiency will develop dark skin. They will look like they have a suntan. It's most obvious in the sun-exposed areas of the body, like the face, neck, and the back of the hands. It can also occur on the mucous membranes. And the easiest way to remember this feature of primary adrenal insufficiency is to know that John Kennedy, President of the United States, had primary adrenal insufficiency, and he always looked like he had a suntan, and people thought that was because he went out on his boat in Cape Cod, and that was part of the reason, but it was also because his levels of MSH were always high because he had adrenal insufficiency and high ACTH. To make the diagnosis of primary adrenal insufficiency, you begin by measuring the plasma cortisol concentration to show that it's low. And the ideal way to do this is to measure the cortisol in the morning. So our cortisol levels go up and down throughout the day. They tend to be highest in the morning and lowest at night. So because they're higher in the early morning, if you get a low cortisol value at this time, this strongly suggests a diagnosis of adrenal insufficiency. At the same time you measure the cortisol, you should measure the plasma ACTH level, and if the patient has low cortisol and high ACTH, this is consistent with primary disease. Low cortisol and low ACTH suggest some form of central disease. And then it can take time to measure the morning cortisol and get the ACTH level back from the lab, and sometimes you want to just quickly exclude whether or not the patient has adrenal insufficiency. And so to do that, you can do something called the cosentropin stimulation test. So let's talk about that now. Cosentropin is a synthetic form of ACTH, and the standard high-dose cosentropin stimulation test involves administering 250 micrograms of cosentropin to the patient. When you do this, the normal response, if the adrenal glands are healthy, is to see a rise in the serum cortisol after cosentropin stimulation. You measure the serum cortisol 30 to 60 minutes after giving cosentropin, and a normal response is for the cortisol level to peak at greater than 18 to 20 micrograms per deciliter. If the cortisol level rises to this range, it means the adrenal glands are healthy and able to produce cortisol in response to ACTH stimulation. And this rules out primary adrenal insufficiency. It means the adrenal glands cannot have any pathology that is impairing them from making cortisol. Otherwise, they would not have been able to boost the cortisol level to this range. A normal response also rules out most forms of central adrenal insufficiency. Remember that in central adrenal insufficiency, there's a low level of ACTH coming from the pituitary gland. This means the adrenal glands are not being stimulated, and so they usually will atrophy over time. And because they've atrophied, you should not see a normal response to cosentropin stimulation in central forms of adrenal insufficiency. The one exception to this is sometimes if patients have central adrenal insufficiency of very recent onset, the adrenal glands will not yet have atrophied, and they will still be able to produce this normal response. So a normal response to cosentropin does not rule out all forms of central adrenal insufficiency. But if you get an abnormal response and the cortisol level does not rise to greater than 18 to 20, then the patient has some form of adrenal insufficiency. This could be primary disease, where there's a blunted rise in cortisol after cosentropin because of adrenal gland pathology and the adrenal glands being unable to make cortisol. Or, as I said, you could see an abnormal response in central adrenal insufficiency because the adrenal glands have undergone atrophy. So once you establish that a patient has primary adrenal insufficiency, what are the potential causes? Well, I've listed some of the important ones on this slide. Autoimmune adrenalitis is one of the most common causes of primary adrenal insufficiency in the United States. This is what John F. Kennedy is believed to have had when he was president. This can occur in isolation, but in many cases, patients who develop autoimmune adrenalitis have other autoimmune disorders as well, and this leads to autoimmune destruction of the adrenal gland. Infectious adrenalitis can occur in patients who have tuberculosis or HIV or disseminated fungal infections. These infectious processes can lead to infection and destruction of adrenal gland tissue. Hemorrhagic infarction is when there's bleeding into the adrenal glands leading to ischemia and death of adrenal gland tissue. This is associated with sepsis from meningococcus, which is called meningococcemia. When meningococcemia leads to hemorrhagic infarction of the adrenal glands, this is called the Waterhouse-Friderichsen syndrome. Hemorrhagic infarction is also associated with anticoagulant use. Patients who take anticoagulants like warfarin and other drugs are at increased risk for bleeding in general, including bleeding into the adrenal glands. And then the adrenal glands are a classic site for metastatic cancer. Now, usually there's not enough cancer growth in the adrenal glands to destroy the tissue and cause adrenal insufficiency. Most often, metastases to the adrenal glands are detected on routine imaging or post-mortem. But rarely there can be enough cancer growth in the adrenal glands that it causes primary adrenal insufficiency. Once you've established that a patient has primary adrenal insufficiency, let's talk about how you determine a specific cause. So in many cases, the specific cause is evident from history and exam. For example, if you know that your patient has disseminated tuberculosis or HIV or meningococcemia, then these things are presumed to be the cause of adrenal failure. There are antibodies against the 21-hydroxylase enzyme found in the adrenal glands that can be detected in some but not all patients with autoimmune adrenalitis. And so if you find those antibodies, that suggests this cause of adrenal insufficiency. And then a CT scan of the abdomen can be helpful. It can show evidence of infection or hemorrhage or malignancy that has spread to the adrenal glands. In some cases, a CT-directed fine needle aspiration is done of the adrenal glands to identify evidence of infection or malignancy. Regardless of the cause of primary adrenal insufficiency, the treatment is fairly straightforward. It always involves corticosteroids, which could be dexamethasone, prednisone, or hydrocortisone. These are the drugs most commonly used. They replace the lost effects of cortisol. And then it also involves mineralocorticoids. The drug usually used for this purpose is fludrocortisone. It's an analog to aldosterone that can replace the aldosterone effects that have been lost. Okay, now let's talk about central forms of adrenal insufficiency. Remember, when there's a central cause of adrenal insufficiency, there's loss of ACTH stimulation of the adrenal glands, and this will lead to hypocortisolism. But production of other adrenal hormones like androgens and aldosterone will remain intact. So patients with central adrenal insufficiency can develop weakness and fatigue. They can also have muscle and joint pains. They do develop hypotension, but it's usually less prominent compared with primary adrenal insufficiency. And that's because these patients only have decreased vascular tone from hypocortisolism. They do not have loss of mineralocorticoids, and they don't develop volume depletion. You can also see hyponatremia in central adrenal insufficiency, but it's less common compared with primary adrenal insufficiency. And once again, that's because production of mineralocorticoids from the adrenal glands is intact. So the only mechanism that causes hyponatremia is low cortisol, leading to high ADH. You won't see skin hyperpigmentation in central adrenal insufficiency, and that's because ACTH levels are low and not high. And then the diagnosis is made by performing testing that's consistent with central disease, just like we talked about earlier in this video. Once you identify central adrenal insufficiency, the evaluation usually involves a head MRI, and that's because there's often some lesion or abnormal process involving the hypothalamus or the pituitary gland. Another test that can be done is a CRH stimulation test. This involves infusion of intravenous corticotropin-releasing hormone, which normally stimulates the pituitary gland to release ACTH. This can differentiate secondary from tertiary forms of adrenal insufficiency. If there's no rise in cortisol levels after infusion of CRH, then the patient has secondary adrenal insufficiency. This means the pituitary gland has failed and it cannot respond to CRH. If, on the other hand, you do see a cortisol rise after intravenous CRH infusion, then the patient has tertiary adrenal insufficiency. That patient has hypothalamic failure. They're not producing CRH, but when you infuse CRH, you get the normal response of a rise in cortisol. And the treatment for central forms of adrenal insufficiency is with replacement glucocorticoids. You do not need to replace mineralocorticoids because their production remains intact. And so here's a table from the White Coat Companion summarizing the workup of adrenal insufficiency. Hopefully everything in this table makes sense to you now. So you begin by measuring a morning level of ACTH and cortisol. If you have low cortisol and high ACTH, that indicates primary adrenal insufficiency. When this happens, you can perform other tests like 21-hydroxylase antibodies looking for autoimmune adrenalitis, or a CT scan of the abdomen looking for hemorrhage or metastases, or like I said, in some cases, a fine needle aspiration is done. If, on the other hand, you have low cortisol and low ACTH, then that indicates central adrenal insufficiency. In this case, tests that are commonly done are an MRI of the head to look for a pituitary or hypothalamus lesion. And then, as we just discussed, you can do the CRH stimulation test to differentiate secondary from tertiary adrenal insufficiency. Let me mention one special cause of central adrenal insufficiency, and this has to do with patients who take chronic glucocorticoids for treatment of disease. Many patients take drugs every day that are glucocorticoids. For example, many patients take oral prednisone or other drugs that have cortisol effects. And the reason they take these drugs every day is because they're immunosuppressants and they're used in the treatment of autoimmune conditions. But when patients take glucocorticoids every day, this will suppress the hypothalamic pituitary adrenal axis. Basically, the oral glucocorticoids will provide negative feedback to the pituitary gland and the hypothalamus. So in these patients who take glucocorticoids every day, the levels of CRH and ACTH are always going to be low. What this means is there'll be very little stimulation of the adrenal cortex in these patients to produce cortisol, and as a result, atrophy of the adrenal gland can occur. These patients who take glucocorticoids every day have an impaired ability to produce cortisol from the adrenal glands because all their cortisol effects are coming from endogenous drugs. It's only cortisol that's affected because the production of mineralocorticoids is maintained by the renin-angiotensin-aldosterone system. It's only the low levels of ACTH that are causing underproduction of cortisol, leading to loss of the ability to produce cortisol. So what this means is these patients are dependent on endogenous glucocorticoids for their cortisol effects in the body. And if you suddenly stop the glucocorticoids or the patient is underdosed, they can develop a deficiency state because their adrenal glands aren't ready to replace the endogenous glucocorticoids with cortisol from the adrenal gland. So in patients on chronic glucocorticoids, you must taper their dose or wean them off of the glucocorticoids. You can't stop them abruptly. If you do, you will cause central adrenal insufficiency. There are various regimens that are used to prevent patients from developing symptoms of adrenal insufficiency when you stop glucocorticoids. Usually what is done is a small decrease in the dose is made every 1 to 2 weeks until the patient has been tapered completely off the medication. And then you should be aware that suppression of the HPA axis is unlikely if patients are on chronic glucocorticoids for under 3 weeks. 3 weeks is sort of the magic number. So if a patient is prescribed a short course of oral glucocorticoids, for example, maybe 5 days or a week, then you don't need to taper the dose in that situation because that duration of therapy is not long enough to suppress the HPA axis. Tapering is only required in patients who have been on long-term oral glucocorticoid therapy, usually 4 months or years. I'll finish this video by talking about adrenal crisis, which is an acute onset life-threatening condition of shock due to the sudden loss of adrenal hormones, especially cortisol and aldosterone. When patients enter adrenal crisis, they will develop shock and it will be poorly responsive to fluids alone. That's because the only way to truly resolve the shock in adrenal crisis is to administer glucocorticoids, and we'll talk more about this in a minute. So when you practice emergency medicine or critical care medicine, you have to consider adrenal crisis and adrenal gland failure in any hypotensive patient. It is always in the differential for life-threatening shock, especially shock that is refractory to intravenous fluids and other usual interventions to try and bring the blood pressure up. Adrenal crisis often occurs in patients who have underlying adrenal disease who then develop an acute stressor. The underlying adrenal disease could be chronic primary adrenal insufficiency. Sometimes patients aren't aware they have this because the diagnosis hasn't been made yet, so their initial presentation is that of adrenal crisis. You can also see it in patients who are on chronic glucocorticoid therapy and have adrenal atrophy. In both of these situations, the adrenal function is unable to increase in response to a stressor. So if a patient with one of these problems develops trauma or has surgery or develops a major illness like pneumonia or sepsis, they will go into adrenal crisis and develop life-threatening shock. And unfortunately, in many cases, the stressor can be presumed to be the cause of the shock and hypotension, and it can be missed that the patient has adrenal failure and is actually in adrenal crisis. You can also see adrenal crisis outside of underlying adrenal disease when patients have the acute onset of adrenal gland destruction. For example, bilateral hemorrhage into the adrenal glands can occur in patients who have sepsis and DIC and coagulopathy. The treatment of adrenal crisis is commonly referred to as stress dose steroids. What this means is an intravenous bolus of the glucocorticoid hydrocortisone, followed by either regular intravenous doses every few hours or followed by an infusion. And the idea here is to replace the lost cortisol effects, and in many cases this will resolve the shock associated with adrenal crisis. Sometimes in the intensive care unit, when patients have shock of unclear etiology and it's not responding to normal interventions, stress dose steroids will be given empirically without testing for adrenal insufficiency in the hopes that the high-dose steroids will resolve the patient's shock. We also try to prevent adrenal crisis by administering stress dose steroids prophylactically in patients who are on chronic glucocorticoids facing a major acute stressor. This is usually only done for patients who take a high daily dose of chronic glucocorticoids and have done so for at least 3 weeks. Remember, 3 weeks is the traditional amount of time that is thought to be required to suppress the HPA axis. So in patients who meet this first criteria here, they will often be given stress dose steroids prior to major surgery or after a trauma or in the setting of major illness. And not every patient who takes chronic glucocorticoids necessarily needs to have stress dose steroids. They aren't necessary for minor surgical procedures, only for major surgery, and they also aren't necessary in patients who take very low daily dosages of chronic glucocorticoids. It's really only for patients who meet these criteria here in terms of the amount and duration of glucocorticoids and the type of acute stressor they are facing. And that concludes our module on adrenal insufficiency.